Right. So welcome, year fours. Hope you've had like a good first few days, probably doing nothing but induction activities. So I'll tell you a little bit about this teaching thing that I kind of started last term. We basically started teaching year fours using like case-based teaching, because it's just a good way of like learning information and like, opposed to just learning it from a book. It's a bit more fun. It's a bit more interactive. It's not for everyone. You might not find it that useful. If you don't find it that useful, like that's fine. Like it's definitely not for everyone. So me and I'm Manoush, I'm a final year, and me and a couple of other final years started this. The rest of the people teaching you here today are all fifth years who came to our teaching sessions last year, so they know the format, they know what's useful, they know what's not useful, and hopefully that'll help them create like an engaging experience for you. I've made some really not so interesting intro slides. Yeah, everything I just said. So this is one of the things I don't really get about the curriculum. Usually you'll go around, you'll learn about a condition, you'll learn about the signs and symptoms, and then you'll learn about the treatment of a condition. But in real life, that's not really how it works. In real life, it's more a patient comes in with signs and symptoms. You need to figure out what's wrong with them and form a differential diagnosis. And then you can talk about management. And we're going to try and focus a bit more with this on this format. Aims. We're going to try and teach some concepts that we think aren't taught so well within the curriculum. Here's a couple of examples. Microbiology, antibiotics, like people are very confused by these when they're taught them. We're going to try and simplify that for you. And Mark here loves his pathology. So he'll be doing some really basic stuff that comes up in exams. Nothing like really complicated. But hopefully it'll be better than just learning it in a week like they try and make you. And like the main aim of these sessions is that like ensure that sessions are engaging and encourage active learning is what that's meant to say. We're basically going to be asking lots of questions and you're going to be doing lots of thinking. The evidence shows that this is a better way of learning than just reading from a book, but if you prefer that, again, go for it. And yeah, we're going to try and focus on clinical reasoning and decision making, so figuring out what's wrong and making decisions based on that. So, before I start, you should probably meet the people teaching. You've met me, I'm Manoush. Izzy?
Hey.
Izzy's a fifth year. You just say what year you're in. James?
Hello, I'm also a fifth year. Looking forward to teaching you guys.
Divya?
Yeah, I'm Divya. I'm also a fifth year.
Mark?
Hey, so yeah, I'm Mark. I'm a fifth year as well.
And Prina, I think is it?
Yeah, I'm here. My name's Prina. I'm also fifth year.
Yeah, they're all fifth years. I'm just old, so sad reacts. Fine. So this is the other big thing. Year 4 looks a bit like this. They put you in these separate modules, but in fact, there's a ton of overlap between all of these modules. So let's try some interaction. Give me a cause of chest pain. Why might a patient be in? Why might a patient have chest pain? You can put it in the chat. Yeah, myocardial infarction, a cardiac cause of chest pain. So is angina. These are all cardiac causes. Cardiology comes under Module A. Pulmonary embolism is a non-cardiac cause. It's a respiratory cause, which comes in Mod A. GORD. GORD is a gastrointestinal cause of chest pain that comes up in Mod B. Basically, you're split into these modules, but they're like every single presenting complaint in year 4 has overlap between all 3 modules. So every session we learn, we'll try and bring together all of these things. So you get like a bit more of a holistic understanding of what's going on, because like within the curriculum, you're taught it in a very linear format, but that's the aim. Fine. This is how we'll do things based on feedback from last year. Term 1 will try and focus on basic knowledge you should know and the skills you need. Term 2 will be based more around cases and clinical reasoning, figuring out what the problem is. If you've seen House, it's like an episode of House, but less exciting. And term 3 will ramp up the SBAs, so you'll be prepared for your exams. We'll also drop OSCE tips throughout, so like you kind of know what to prepare for. So what is a differential diagnosis? I won't spend ages on this, but like it's a useful thing to know. So this is like a key concept in clinical medicine. You may or may not have had a lecture on this. No. So a differential diagnosis is the possible causes of a certain presentation. Yeah, exactly. The different potential diagnoses that are causing the signs and symptoms that you see in front of you. And importantly, the differential diagnosis must eventually lead you to the correct diagnosis. You use investigations and history taking, you form a differential from a history and you use investigations to try and narrow down that differential diagnosis. And you should try and organize it logically. This will help you think about various things. And you won't forget like causes if you use something like a surgical sieve, or like we did with chest pain, think about it, lungs, GI, chest, cardiac. So like try and structure it. It makes you sound slick in an OSCE if you can structure your differential diagnosis. When you hear hooves, think horses, not zebras. Does anyone know what I'm trying to get at here? Again, this is something that will be emphasized in your lectures. If no one answers, one of the year 5s can answer, because think of the most common things first. Yeah. So yeah, the rare things are really interesting. Like I like rare diseases, as do most of us. But remember to think about the common things first. Ooh, someone had their hand up momentarily. And yeah, this, as I said, today is going to be a longer session purely because these are 3 skills like you'll probably see regardless of what module you're starting on or whatever placement you're starting on. So we kind of want to get them out of the way. And then this is the plan for the next few sessions. After that, it's going to be kind of based on the feedback you provide. So you tell us what you want to learn about or what you're struggling with, and we'll try and incorporate some kind of teaching on that. We've been through the exams you're going to study. We kind of have cheat ways of simplifying things, and we can teach things slightly differently to try and help you understand them. So yeah, just let us know. I'll get you to fill out a feedback form after each session. I'll read the feedback like literally every week because I have nothing else to do apparently. And we'll try and go from there. Right, intro done. Damn it, 12 minutes too long. Session 1, intro to year 4 data interpretation. I sent out a link, which is like, how do you actually get the most out of year 4? Basically, go in and talk to patients is like the key thing. 3 things before we start. So these are 3 definitions you need to know. So what is a symptom? Or rather, what's the difference between a symptom and a sign? So this is something that like consultants love being pedantic about. So yeah, it's something a patient feels or the patient reports. And yes, a sign is something you observe or a trained person will observe when examining or looking through a history. And a presentation is just a combination of the signs and symptoms that the patient presents with. So if a doctor asks you what symptoms will someone get with this condition, try not to jump to the signs and vice versa. Okay, ECGs. So this is by no means an exhaustive list, like tutorial on ECGs. We'll talk about some common patterns and how you can use a systematic approach to like analyze an ECG. What we won't be doing is figuring out like all of the details about ECGs. I think James will probably do like a session on like ECGs in detail later on, but that's not useful in week 1. In week 1, you just need to know how to spot the common things. So we'll make a start on that. You need to know this for OSCEs. This will come up. I'll send out the slides. You don't need to read these, but these are the positions of the leads. You have your precordial leads and you have the limb leads. A good mnemonic for this is ride your green bike. I'm not going to talk about it too much because you can read this in your own time. And these are where you place the precordial leads. So when you form your OSCE groups and start doing some OSCE practice, yeah, have a look at these. And this is kind of the system I use to analyze ECGs. So we'll talk a little bit about what calibration means. But you want to ask yourself, is this a regular rhythm or an irregular rhythm? Then you're going to calculate the rate. And then you go through each bit of the ECG and try and figure out what's going on. And if there are abnormalities, which leads they fall under. This doesn't make sense without an ECG in front of me, so I will move on. But yeah, James will do like a more detailed session on this, but we're going to do some really, really like key diseases that come up all the time.
Can I pop in and say, it seems like you guys have had really good online teaching from like Dr. Lovell. So it might be useful if you could let us know in the feedback how much you want from ECGs, whether you're feeling comfortable with what the different leads are and how to create how to find out the axis of the ECG, which I think a lot of people in my year at least struggled with. And then that I can base that on what you guys need. Yeah.
Like our job here is to kind of like focus on things that might not be covered so well. So let us know what you want exactly. Fine. So a normal ECG will have these various parameters. You can memorize these if you want. You probably should. I don't think I ever did because I'm useless. The calibration is basically you'll have a box at the beginning of the ECG and it will show you what 1 volt looks like and what a number of seconds look like. You should look at a real ECG to figure out what's going on, but in real life we just skip the calibration. In an OSCE they'll expect you to check the calibration. Ask a doctor to show you how to check it. Hopefully they will know. And lead localization. So this is what an ECG basically looks like. It'll be split into like 12 different sections, and each section shows a part of the heart. So in this diagram, which is basically a simplified version, the blue is areas of the heart supplied by the left anterior descending artery, which is the front and the middle of the heart. The green areas are the lateral side of the heart, so the left-hand side, and those are supplied by the circumflex artery, and then the red/pink is the inferior, the bottom bit of the heart, and that's supplied by the right coronary artery. This is the extent of coronary artery anatomy you need to learn. You do not need to learn any more than this for year 4. Like you probably learned more details for year 1, but you definitely don't need to know more than this. Also, if you think back to year 1, you have the nodes which set the pace and then conduct electricity, and these are both supplied by the right coronary artery. So that's like the basic principle. We can come back to this. The best thing to do is to just look at some patterns. So, does anyone want to have a go at this one? It's fun. As in, the other thing I want to emphasize is it's good to get things wrong. You don't really learn unless you get anything wrong, as everyone can verify. So, is this a regular rhythm? Yes or no? This is not a regular rhythm. Type 2 Mobitz. Interesting. This is atrial fibrillation, actually. So this is one of the patterns that you should always look for. So easy thing, are there P waves? So if I go back to the slide with parts of an ECG, if there are no P waves, i.e. there's no little bump before the QRS complex, this is atrial fibrillation. Like, there's your mark. You don't need to do anything else. So that's one of the patterns you need to just learn to recognize immediately. It's super simple. Look for P waves. Are there any P waves? No, atrial fibrillation. And yeah, you're right. It's not regular. Atrial fibrillation is a cause of an irregular pulse on examination. Fine. What about this one? So are there P waves? So this is atrial flutter. You guys have had good ECG teaching, clearly. This is flutter. it has the sawtooth baseline. If you see a sawtooth baseline, it's flutter. So those are two patterns you just get right off the bat. Any idea what this is? You don't need to go through the entire spiel for these patterns. This is VTAC. So we'll talk about, so torsade de poids is basically VTAC, but you'll get large waves and small waves. It's kind of like a sine curve. So like, yeah, it looks very similar, but this is torsade de poids. This is not torsade de poids. This is just VTAC. I can understand why you said that, because in V3 there's smaller waves, but I think that's just based on the position of the lead. Okay, now what's this? Yeah, that's a good thing. Yeah, now this is torsade de poids. So if you have, so there's a congenital syndrome called long QT syndrome, and then if you give them drugs that also prolong them their QT interval, they can get torsade de poids. You give magnesium sulfate. This is another pattern to recognize. Basically, the first 6 patterns on this list you can just recognize by literally looking at the ECG. Just learn these ones. Yeah, thanks, Divya. That's a good image to show you what torsade de poids looks like. Okay, and then last one. I think this is the last really obvious one, and then we get onto the less obvious patterns. If you didn't know these, it's fine. Just try and recognize these in the future. Like, it just saves you time in an exam. So this is VFib. There's no pattern. It's completely random. There's literally no pattern to this. It's completely random. So these are all tachycardias. Tachycardias are defined as arrhythmias where the heart rate is greater than 90. You can get narrow complex tachycardias where you have a QRS that's less than 3 squares. You can have broad complex tachycardias where it's more than 3 squares. What's the commonest cause of a tachycardia that I haven't listed on this slide? So if I go, yeah, so exercise induced or sinus tachycardia. If you have an adrenaline rush, if you're running, anything like that, pushes up your heart rate, that's a tachycardia. That will be a sinus tachycardia. Remember that it's not just exercise that causes that. It can also be like being generally ill, having an infection can cause that. So yeah, that's the commonest cause that I haven't put on here. And so the big thing to remember is narrow complex tachycardias come from the atria. So the signal comes from the atrium. It goes through the atrioventricular node, and then the contraction of the ventricle starts via the bundle of His, and it all contracts at the same time, which is why you get a narrow complex. It's all synchronized contraction. With a broad complex tachycardia, you don't have the conduction through the AV node and the bundle of His. So the contraction of the ventricles happens in a random fashion. So it doesn't contract at the same time. So you get kind of this prolonged contraction period. So you get a broad complex. So remember, if it's gone through the AV node and the bundle of His, you get a narrow complex. If it doesn't go through those and it just gets conducted through the heart tissue itself, you get a broad complex. So here's a complicated question that you may or may not know the answer to. When could you get a broad complex tachycardia that comes from the atrium or from the sinoatrial node? In what situation? This is something I only knew at the end of the year. So yeah, you can have like these re-entrant tachycardias that if they go in the wrong direction, that could be the cause. Commoner than that though. I'm not going to talk about re-entrant tachycardias today because they're kind of complicated. They're just a subtype of SVT, which is a supraventricular tachycardia, which means any tachycardia that originates above the level of the ventricles. Year 5s, any of you know the answer?
Is it an SVT with aberrant conduction?
Yeah, so if you have any of the narrow complex tachycardias, specifically the SVTs usually, and you have an AV block, then you get a broad complex, and it's a differential diagnosis to be aware of, but like it's unlikely to come up in an exam, but like some annoying cardiology consultant's probably going to ask you about it. Fine. And then you can have a high heart rate or you can have a low heart rate, and low heart rate we call a bradycardia, and you can split it into the 3 types of a bradycardia. Type 1, type 2, type 3. Type 1, you simply have a long PR interval. So the distance between the P wave and the start of the QRS complex is more than 5 small squares. And then type 2 splits into Mobitz 1 and 2. Mobitz 1, the PR interval gets longer and longer and longer until it drops a beat. Mobitz type 2, you have a normal PR, but you randomly drop QRS complexes. And type 3, there's no association between the two. So it's really hard to tell type 3 in exams, so make sure you take your time to distinguish between them. A quick treatment thing: type 1 and Mobitz 1 are not worrying unless the patient is symptomatic, then you might pace. Type 2 and type 3 are worrying because they're not that predictable, so you always need a pacemaker. That's the definitive management. Right, your turn. So you know that all of these are, so I've told you that all of these are bradycardias. What bradycardia is this? So remember to look between the P wave and the start of the QRS complex. Mobitz type 1 is the first guess. Correct, this is Mobitz type 1. So the ECG usually has 12 regions, but this one has an extra 4 because the bottom line is just the rhythm strip, which is the best one to look at for stuff like this. So if you look at the bottom left, you can see there is a normal PR interval followed by a slightly longer one, and then a longer one, an even longer one, and then a dropped beat. So if you look at the bottom left, you will be able to see that this is Mobitz type 1. Fine. What's this? I've only given you the rhythm strip. So if they only give you one strip, it's probably lead 2, and that's the rhythm strip. So yeah, this is type 1. This is just a long PR interval. So this is first degree heart block. I've given you some arrows to make this one a bit easier. Is the PR interval long or normal or short? Any ideas? Yeah, so this is Mobitz 2. The PR interval is short, normal, probably normal in this case. And they've just randomly dropped a ventricular beat here because there's no QRS complex. So yeah, this is a Mobitz 2. Would you treat this person? Yeah, treat them. Put a pacemaker in probably. Good. And then here's probably the most complicated ECG thing I'll talk about. So bundle branch block is where, so you have your bundle of His that come from the AV node. The bundle of His splits into 2. The left-hand side supplies the left ventricle. The right-hand side supplies the right ventricle. you can block one of these branches and they'll cause a really distinct M-like pattern in the Q wave. If you get an M pattern in V6, around V6, then it's left bundle branch block, and then if it's in V1, it's right bundle branch block. I say around V6 and around V1 because technically it could be in like V2 or it could be in V5 respectively, depending on which one we're talking about. Just look around for the M pattern generally. If you pick this up in like at the start of the year, the doctors will be very impressed. So what is this ECG showing? So yeah, there is an M-shaped pattern in V6. So this is left bundle branch block. And then, I mean, what is this showing? The other one, yes. So this is right bundle branch block. And as I said, it might be in V1, but here it's clearer in V2. So just look around to like one adjacent lead, because it's not necessarily always going to be in V1 because of anatomical variation. Yep. Right. ACS, huge topic in year 4 in cardiology. These are the 3 components of ACS. Unstable angina, you don't have cardiac muscle death, so the troponin is a normal. Troponin is an enzyme that's released when cardiac myocytes die. In myocardial infarctions, they die, so you get a raised troponin. But you only get, so this is a key thing that comes up a lot. ST elevated MIs cause elevation of the ST segment. I know that's obvious, but that's what you need to look for on the ECG. Here's some voltage criteria that they probably won't ask you about in exams. In exams, they tend to give you really obvious cases of heart attacks. If it doesn't have an ST segment elevation, it might have one of these other features like T-wave inversion or ST depressions, but those are a lot more subtle and they're less likely to come up in your exams. So in my exams in year 4, I got like one barn door STEMI. I'll show you what it looks like in a minute. I don't know, did the year 5s did you get any MI questions last year, ECG?
I think we got one, or we got it in the mock exam, definitely. But that was the one that we talked to you about. It was the one with the new onset left bundle branch block, and it was really confusing.
Yeah, but that was a mock exam. That doesn't really count. They always make it a bit hard. Yeah, they tend to be pretty barn door. So, what mnemonic do you use for like taking a history from someone? There's a really good mnemonic for history taking. Have you had a session on history taking? I hope so. Socrates, yes, yeah, exactly. So run me through Socrates really quickly. What does it stand for? Site, yeah. Onset. Character, yeah. Keep going. I hope you're not looking at your notes. Radiation, yeah. Almost there. What's A? After R is where people tend to start forgetting things. Associated factors, associated symptoms, yeah. That's the hardest question, I think, because there's a million associated things to everything. Time, so time duration or onset. Oh, wait, no, we've done onset. It's just time duration. 2 more, E and S. E is exacerbating or relieving factors. So you care about both, yeah. And severity, yeah. So let's talk about a heart attack. Where is it going to be? You can't point, but you can describe it. central in the chest. Yeah, not central anywhere. Onset, so how quickly does it come on? Generally. It tends to be pretty quick, but yeah, it does vary. Just one thing to remember, heart attacks are more common in people with diabetes, and people with diabetes might not get chest pain. They can get this thing known as a silent MI, just for exam reasons. It's just something to be to note. Character, how will they describe the pain? So yeah, remember, when you ask a patient, you're not going to say, what's the character of your pain? It's like, how would you describe your pain? Yeah, crushing, dull, tight, these are all things. Elephant on chest is a thing that they love to say in textbooks, yeah. Radiation, where does it move to? Where does the pain move to? Neck, jaw, arm, on the left-hand side, yeah. So left-hand side specifically. In what scenario would it move to the right-hand side? If the heart's on the other side, absolutely. What's that called? Tachycardia, yep. Oops. Here are some associated symptoms you should ask about. The only thing is, when you're history taking, you can't just ask about these two associated symptoms. You need to ask about associated symptoms for as many causes of chest pain as you can think of. So we spoke about GORD earlier. You might want to ask, do you get any heartburn? We spoke about a pulmonary embolus. You might want to ask, do you have pleuritic chest pain? So chest pain when you breathe in. So these are the associated symptoms for an MI, but you do also need to ask about other ones to rule out the other causes. Fine. Time, it's variable. Exacerbating or relieving factors. So what makes heart pain better? Well, ischemic heart pain. So if someone comes in with a heart attack, what do we give them to treat their pain? And so GTN and nitrates are usually used. They're very effective in angina. You still use them in ACS, but it's often not relieved by it when they use their puffs. But yeah, that is an important thing. You do use that in the management. Aspirin reduces. So aspirin's an antiplatelet. It doesn't really help with pain so much. You give it for prevention. What do people get addicted to? What's the best pain relief for cardiac chest pain? Opiates, yeah. So if someone comes in with acute coronary syndrome, myocardial ischemia, you usually start them on morphine, unless it's like angina. You start them on nitrates and morphine. But yeah, so if they're having an MI, GTN doesn't really help that much, but opiates will help more. But you still start them on nitrates. Severity, really freaking bad. Fine. We spoke about lead localization, and lead localization is very important when it comes to locating which artery is blocked. So keep this diagram, take a photo of this diagram before we look at the next slide. So everyone take a photo of this really quickly, or a screenshot, or whatever you want to do. Right, I'm assuming everyone's done that. Actually, I'm going to post a screenshot of it in the chat for your own convenience. Right. There we go. You will need so try and learn this diagram roughly for exams. Right. Is there ST segment elevation in this ECG? Yes or no will do. Oh, you can't see the slides changing. Okay. Yeah, there is. Neeraj, I think your internet's broken. I hope it's changed now. Okay, there is ST segment elevation. In which leads is this ST segment elevation most prominent in? So V1, V2, yeah, so that, yeah, correct. Now, if you look at that diagram I asked you to take a photo of, yeah, those are the anterior leads, which is supplied by which artery? Anterior septal are supplied by the left anterior descending artery. Yeah, exactly. And these are the kind of questions they ask. So, like, you'll probably do past med. It'll give you an ECG, and they're like, which artery is occluded? So they'll give you this ECG, and you'd say the left anterior descending artery is occluded. Okay, fine. Try this one. It's a bit more subtle. So that one was really, really, really obvious. This one is only slightly obvious. Also, to make a quick note, when I send these slides out, I've hidden a few. There's a few extra ECGs of slightly less common things that you can look over if you get bored. So where is there ST segment elevation, and if so, where? Neeraj is on fire. So yeah, there is ST segment elevation in leads 2, 3, and AVF, which is the inferior territory supplied by the right coronary artery. There you go. Where is it now? LAD again, so V2, V3, V4 are the big ones. This is the same as the first one. What about this one? I think this is the last MI one. How are we doing for time? We're doing good for time. So where is the problem? So yeah, this is a circumflex artery blockage because this is a lateral STEMI. The only real elevation is in lead 1 here, but there's also some reciprocal changes, so flipped changes in lead 3. But you don't really, if you can recognize the elevation, that's sufficient. Oh, there's more. There's more. The really obvious one is lead 1. Do you want a break? Yes or no? We can take 5 if you want. We're halfway through. Exactly. No, I don't think anyone else. If anyone really wants a break, just say yes. It's recorded anyway. Fine. I'm going to hand over to Mark, who's going to talk about chest X-rays. Mark, if you click take control.
Cool. So I'm going to bring you guys through the basics of chest X-rays once I take control. I can't get a pointer, can I, Anush? No, because I think you guys are just going to have to believe me when I tell you things are where they are. So chest X-rays are probably one of the most common investigations you're going to see when you're on the wards. Pretty much every patient that you'll see in hospital will have had a chest X-ray on the system. They're useful for looking for solid lesions. They're useful at finding fluid in the lungs, either in forms of consolidation or in the pleural space, so in effusions or pulmonary edema. And it's great at looking cavitating lesions such as tuberculosis, right? We also order chest X-rays when we do procedures. So when we put a chest drain in or an NG tube in, you order a chest X-ray afterwards to see that it's sighted properly, right? I don't know, have you guys had teaching on chest X-rays yet? If you have, then you may have already seen, okay, you haven't, okay. So there's a good systematic approach to take to interpreting chest X-rays, much like Nush said with ECGs. If you have a good system, it makes things a lot easier. You're not going to miss anything. So a great way of doing it is, it's not put here, but RIPE and then A, B, C, D, E. So when you first encounter a chest X-ray, you should, or when you're first presenting a chest X-ray to any of the consultants or to the juniors, you should always state the name, the date of birth, the identifiers of the patient. You should then take the date that the chest X-ray has been taken on, right? And then you should also see if there's any, or comment if there's any previous imaging. The next thing you should do is you should comment on the technical quality of the chest X-ray. Yeah, like Anush said, it is a universal system, so it's good to learn the ABCD. I don't know, Anush, do you know RIPE, just for commenting on technical aspect, if you can put it in the chat as well. So with commenting on the technical aspect of it, you're looking at the rotation, inspiration of the chest X-ray, projection, is it AP or PA, and E as in exposure, how saturated, how much X-ray has the patient been exposed to, right? And I'll mention that all when I show you the first X-ray. Then the other, then going into commenting on the chest X-ray itself, look at A, airways. So you're going down the tracheal, the trachea, look at the carina, then the left and right bronchi, right? Then you're into the hilum, okay? Then you move on to breathing. You're looking at the lung fields. So follow the lung markings all the way to the edge. Compare like with like, and work your way down. See if there's any abnormalities to comment on. And then you're looking as well after the lung fields. You're looking at the pleural space. Okay. Then C, you're into circulation. You're looking at the heart borders. You're looking at the cardiothoracic ratio. So how big is the heart in the chest? D, then you're looking at the diaphragm. Okay, you're looking at the recesses of the diaphragm, the silhouettes that it forms, and you're looking under the diaphragm as well, which is important. And then E, extrapulmonary features. You're looking at the bones, so the ribs, the shoulders and the scapula that you can see, as well as the clavicles. It's good to comment if you see any fractures in those. You're looking at the arch of the aorta, the aortopulmonary window, and then any lines that have been put in or that you see on the chest X-ray. All right, I'll go through this as we talk about as we go through each chest X-ray. So let's take a look at some cases. The first one, this is a normal one. So if anyone, so we'll go through it together. I've already given you present the patient's details and everything. Why don't we start with rotation? Does this look like it's rotated to anyone? Good, yeah. And a good way to tell is, I don't know if you can see it, but if you follow the clavicles to their most medial points in the center, if you find their most medial heads, you should, a non-rotated chest X-ray, you should be able to see one of the spinous processes like equidistant between the two heads of the clavicles, okay? What about inspiration? Does this look like it's adequate inspiration? Does it look over? Does it look under? Does anyone know what you're kind of counting or looking for when you think when you're trying to judge inspiration? So when you're asked to comment, no, not really the lung apices. What you're looking for is how many ribs can you see in the chest X-ray field? In the lung fields, right? If you can see about 5 or 6, that's good. That's a good level of inspiration. Okay. If you see more, the patient might be hyperexpanded. Right, their chest might be hyperexpanded in the case of COPD, okay, or asthma or chronic asthma. If it's underinflated, if they don't inspire properly, if it's underinflated, the bases will be a bit hazy, and it might look a bit like consolidation, but there really isn't, and the heart may look a lot bigger than it actually is. Okay. Projection. What are most? Does anyone know what most? What projection most chest X-rays will be? Yeah, PA, right? So it means that the patient is hugging Usually if they're erect, they're hugging the board, and the X-rays are coming from behind them. Okay, it's important to note the difference between the two because you can't comment on cardiomegaly on a AP chest X-ray because it magnifies the heart. Okay, and then exposure. How does this X-ray look to people? Does it look overexposed, underexposed, adequately exposed? Yeah. So if you look at a chest X-ray and you look at the heart, you should be able to just about make out the vertebrae behind the heart, and that is a good quality or an adequately exposed chest X-ray. Okay. So now that we've run through the technical quality, let's just take a quick look at running through A, B, C, D, E. Right. So A, airway, follow the trachea down, look for tracheal deviation. So in this one we don't really see any. Try and follow it down to the carina where you can see where the right and left bronchi split off. Okay. Then follow it to the hilum. Right. The hilum they're basically where the pulmonary vasculature and bronchi enter each lung. There should be lymph nodes in this region. I'll talk about the pathology as we go on later on down the line with it. But in theory, the left on a normal chest X-ray, they should be equal size, but the left hilum should be slightly higher than the right. Okay. Then you're looking at the lung fields. Follow the pulmonary markings. Okay, there's these little lines, whitish lines in lung fields. Yeah, that's a good picture of the hilum actually. Left hilum. You should be able to follow most of them to the end of the lung, right? And then you can't see the pleura right now because the lung is fully inflated, and there's no pathology within the pleura. Unfortunately, I asked Anush about that earlier. I don't have access to be able to use a pointer. Let me see if I can find something.
I'll try and find it. You continue to know.
All right. Once we have it, I'll be able to point it out. So where was I? So that's B. That's breath fields. Next, you're looking at cardiac. So you're looking at the heart. The only thing really to comment about the heart is the size of it. The entire size of the heart should be less than half the total thoracic width. Okay. So if it's greater than, there's probably cardiomegaly present. D, diaphragm. The main things you're looking for when you're looking at the diaphragm, is it nice and curved like this? Is it flattened in the case of hyperexpansion, hyperinflation, right? COPD or chronic asthma. Then you look at the recesses. So you look at the costophrenic recesses, right? At the edge of each of them. Usually these will fill with fluid if there's consolidation or if there's an effusion. These will be obliterated, they'll be hazed out. And then you can also look at the cardiophrenic angles, right? Which are just where the diaphragm meets the cardiac borders, all right? And these, again, will be lost. So on the right, in a right middle lobe pneumonia, the right heart border and the right cardiophrenic angle will be lost, okay? Then back to just one more on the diaphragm. Look for air under the diaphragm. You should normally on the left side be able to see the gastric bubble, which you can see a little bit here. But if you find a line of, why would you, if I have abdominal pain and I come into A&E, why would they get would anyone know why I would get an erect chest X-ray? Why I would get a chest X-ray standing up? It's okay if you don't. Yes, exactly. Free air under the diaphragm. So you'll be able to see this as just air accumulating underneath the diaphragm. What am I trying to say? It'll just look like a giant line of gas underneath the diaphragm, right? And it'll make the diaphragm look a little bit more clear lined. Everything else. If you're looking for rib fractures, you can follow the rib from all the way at the back to the front. Look at the cortices. If there's a bump or a break in them, probably have a fracture there. Okay, and you can do that all the way down. for each rib. Compare left with right as well. You can comment on the clavicles, the scapula. Okay. Good chest X-rays would involve the head of the humerus as well. Some people have missed shoulder dislocations and shoulder fractures on chest X-rays, so it's important to look out for stuff like that. And then look for lines, right? So if the patient has, say, a central line in, it'll go all the way from the right side of the neck down into the heart. If they got an NG tube in, it should go along behind the trachea, past the carina. Okay, and you know it's not in the lung. What else is on the slide? Scapula. Okay. A good chest X-ray, the scapula will be out of the lung fields, but if they're just straight white lines going diagonally across the upper lobes of the lungs. Okay. Nothing to really panic about in terms of it. But overall, this is a normal chest X-ray interpreted using the ABCD method. Okay. Now just some. Anush?
It's worth noting that most healthy people will have a PA chest X-ray where they're, as Mark said, they're hugging the monitor. If someone has an AP chest X-ray, that means they're probably bedbound or very unstable. So that gives you a little bit of an insight into the condition of the patient. They might be quite ill if they've got an AP chest X-ray.
Exactly. So if they're bedbound, they won't be able to get up. It'll be a AP chest X-ray. The only difference that an AP chest X-ray really makes is that you can't comment on the if they've got cardiomegaly or not accurately. Right. So does anyone want to try and point out? I know this is a little bit grainy, but can anyone point out the glaring abnormality on this chest X-ray?
This is the quality of image you get in your exams. By
Exactly.
the way.
Yeah. This is
not.
the kind of thing UCL will give you. So it's good to start getting used to it. Yeah. Good. Yeah. There's which lung is it in? So it's good spot. Tell me which lung it's in. And for extra marks, tell them you can kind of give me a zone as well. So the left. Yeah, very good. And can you give me a zone? So the lung, I neglected to mention, that's fine. So the lung, when you're commenting on areas in the lung fields, the right lung is split up into upper, middle, lower zones, and the left is, again, upper and lower zones predominantly, okay? You don't refer them as lobes when you're talking about chest X-rays. But good, yeah. So this is obviously quite a large tumor in the left lung. Okay. Yeah, cancer. Okay. Anyone want to make a comment on this chest X-ray? If I tell, it might be a bit difficult off the bat, but if I tell you this guy was working as a construction worker in the 70s, what might you think?
Always remember to describe it before you come up with a diagnosis.
Yeah. So like Anish said, describe it. So what do you kind of see? Not really mesothelioma. It's something that might occur from asbestos exposure, like you said.
Before you get to the diagnosis, what do you see? Like, how would you describe it to someone who knows nothing about medicine?
Yeah, how would you? What does it look like? Is on the chest X-ray? If you lots of shadowing by light, yeah, exactly. So there's lots of well demarcated plaque-like shadowing in both airfields. Okay. So you guys are right on the track that this is due to asbestos exposure. But because you guys haven't really, you might not know, but you can develop what's called pleural plaques from asbestos exposure, right? And this is kind of you can kind of tell they're pleural plaques by looking at it. It's a classic kind of chest X-ray appearance. Anush, if you can find one to put in the chat, that might help them as well. It's not a premalignant lesion. is a good thing to point out as well. But again, and I think something of note as well is if you never interpret a chest X-ray without some, well, try and always interpret a chest X-ray with some clinical correlation. So there's no point blindly guessing what a patient has. It really, really helps if you have some bit of history with it. I know most of the time you're going to be just given a chest X-ray and both to kind of come up with a diagnosis, but always take it with clinical correlation. So with this one, does anyone want to comment on how this chest X-ray looks? Where is there an abnormality? Where is the abnormality? Does anyone want to comment on the technical quality of this chest X-ray? Yeah. I suppose I would say I don't know, Anush, what do you think? I think this is a bit underexposed because I can't see the verbal column behind.
Yeah, so I would say it's underexposed. I understand why you said overexposed because it does look very bright.
Yeah.
But yeah, technically this is underexposed. I know that it's really bright, but you would say this is underexposed because you can't see the vertebrae behind the heart.
Eggshell shadowing. Niraj, do you want to just tell me where exactly you're seeing the pathology first before coming up with a technical term? If I had no idea, if I wasn't teaching you about chest X-rays, do you want to just tell me where you see the bilateral hilar lymph nodes? Okay, yeah, that's a good way to put it. That's pretty much exactly what's going on here. There's hilar enlargement on both the left and right side. Yeah. And, of note, and this is for most of the teaching, right? When if Anush or Izzy shows you a chest X-ray that looks like this, there's only one answer that they're probably going to want, and that is sarcoidosis. Okay. Exactly. Just so you guys know. But there are other causes of bilateral lymphadenopathy, right? One of them is lymphoma, okay? But good. So yeah, bilateral lymphadenopathy. TB can also cause it as well. Actually, I forgot. But TB mostly you will present unilaterally. Anyone want to give me another unilateral cause of hilar enlargement?
Side note, this comes up a lot in exams, just generally. This typical chest X-ray, this is a very classical pattern.
Yeah, malignancy, exactly. Good.
Yeah. So specifically a lung malignancy is more likely to cause, you would say like lung cancer will cause like a unilateral lymphadenopathy, because technically lymphoma is also a malignancy. So just try and specify something.
Yeah.
Yeah. Good thinking though. Yeah.
So let's talk a little bit about pleural fusions. There's two. You can split effusions into two broad types. Well, actually, let's start with effusions. What are pleural fusions? They're basically just collections of fluid in the pleural space. Okay. You can split them up into two broad categories. You can have your transudates, which have low protein content, and you have your exudates, which have high protein content. You guys may remember Starling's laws in terms of fluid dynamics, right? You should, but I don't blame you if you don't remember it. If you're having, basically, if there's increased hydrostatic pressure, you're going to have fluid moving into a space more than it's coming out in a balance, right? If you have reduced oncotic pressure being the pressure that proteins give to pull fluids out of the extravascular space, then you're going to have fluid accumulating in the pleural space. And if you have increased capillary permeability, right, fluid will leak into the extravascular space, in this case, the pleural space, okay? So your main causes of transudates are heart failure, nephrotic syndrome, because you're losing protein, right, out of the kidneys, or liver cirrhosis because you're not producing enough protein to maintain oncotic pressure, okay? Your exudates are any condition that causes a kind of high protein content in the pleural space. So infections will cause an exudate. Cancers, right, will cause pleural fusions. Like you guys mentioned mesothelioma before. Mesothelioma will the 2 or 3 cases that I've seen of mesothelioma have all presented as pleural fusions and exudative pleural fusions. Autoimmune, classically, will be RA or lupus, very much likely to cause an exudative pleural fusion. You can also have a chylothorax or chyle in the pleural space. That's another cause of exudative. And hemothorax, blood in the pleural space, will be classified under exudates as well, technically. Okay. Before I move on, does anyone know?
It's useful to mention.
Yeah.
On topic. So, so COVID can present with a pleural effusion by the ARDS process.
Yeah.
So topical, and you might see this in the coming months if we hit a second peak, which is quite likely.
Yeah. Just on COVID as well. I mean, a lot of what we saw. So when I was in Barna, a lot of the chest X-rays that they showed me at the time, they showed bilateral diffuse consolidation in both fields, and that's kind of your typical ARDS pattern as well. So you can present with effusion, or it can present as like almost a whiteout of both lungs. Does anyone, before we move on, I'm probably going to show you a pleural fusion on chest X-ray next. Does anyone kind of know what you're looking for? What on a chest X-ray with pleural fusion? What might you see? If not, don't worry. Yeah, exactly. A meniscus. So this is a very good example of a left-sided pleural fusion. And I mentioned it before when I was talking about commenting on the diaphragm. Does anyone want to? Sorry. There's a loss of the diaphragm, left costophrenic. Left costophrenic recess, right? And there's actually a loss of the left cardiophrenic recess, too. Okay. And then, as was said, you can make out a clear meniscus at the top level of the effusion. So those are the kind of things you want to comment on if you pick up an effusion. What's next? Pneumonias. Usually pneumonias are confined to single lobes. Sometimes they'll move. So you can broadly classify pneumonias into 2 categories: lobar pneumonia or bronchopneumonia. Okay, lobar pneumonias usually confined to diffusely along a single lobe, whereas bronchopneumonias are patchy consolidation involvements of multiple lobes. Okay, but majority of the time it will be confined to a single lobe. They appear as consolidation, i.e., is that you'll be able to see air bronchograms, and air bronchograms are basically if my pen is the bronchus and my hand is the consolidation, you'll basically be able to see the shadow of the pen superimposed on the consolidation, okay? And it forms like that silhouette. Again, like I mentioned before, lungs are split up into lobes. So on the right side, you have your upper, middle, and lower lobe. Your left side, you have 2. You have the upper and lower, but you also have the lingula, which is a part of the upper lobe, okay? Which is like the middle lobe of the left lung. You'll be able to kind of spot consolidate. You'll know kind of where which lobe it's in by where the consolidation is. So if you've got consolidation that makes the right heart border hazy, like you can't really see the right heart border, then it's likely to be in the right middle lobe. Okay, if you lose, say, the nice clear definition of the diaphragm, for example, it's likely to be in the lower lobe. Upper lobe, it'll be obvious. There isn't really a silhouette to lose in the upper lobes. but you'll notice it much more easily than you will anywhere else. And then, does anyone? I mean, Anusha, we were talking about this the other day. Does anyone know what? So I mentioned PA and AP projections, right? But there's one more projection that you can do in chest X-rays that isn't really done nowadays, except really for lingular pneumonias or lingular consolidation. Lateral, exactly. Very good. Lateral chest X-rays. Apparently only used nowadays for lingular consolidation. So let's take a look.
I love how everyone always knows the rogue stuff.
Yeah. Good. Does anyone want to make a comment on this chest X-ray before I point out anything? Is it normal? Is it abnormal? Where's the abnormality if there is one? Yeah, good. Well done. So yeah, it's lower lobe consolidation on the left side. You've got this hazy consolidation that's blurring the diaphragm on the left side and the cardiophrenic angle at that on the left. Good. So sometimes you're not gonna be able to, I'm not the best at picking out air bronchograms, but this is quite clear. You can see where the arrow is pointing. You can see that there's this air tube, this air line kind of passing through the white haziness. That is an air bronchogram. And actually that's one of the nicest ones you'll ever see. Most of the time you'll kind of just notice consolidation before you notice an air bronchogram.
If you see what looks like a left lower lobe consolidation and you don't see air bronchograms, you should consider an effusion instead.
Anyone want to describe this one? It's all right if no one wants to answer, it's all right. So on this chest X-ray, it's basically the right. There's a right lower zone consolidation. Yeah, and you can see an air bronchogram pass in kind of the upper margin of it as well. But yeah, so there's complete loss of the right cardiophrenic angle. There's haziness of the diaphragm borders itself, but you can actually make out part of the right right heart border. So this looks like it's lower lobe. Yeah, there you go. And like we mentioned before, so this is a lingular pneumonia, and it's taken from the aspect of a lateral chest X-ray. Does anyone want to tell me what that line is towards the back of the consolidation on the lateral view? It's an anatomical marking of the lung. I will test you guys loads on your anatomy. I love my anatomy, Anush. I absolutely love it.
Mark is one of the only people that really likes anatomy.
One of the fissures, exactly. Do you want to say, it's a 50-50 guess as to which fissure it is. There's only one fissure in the left lung. Do you want to have a go? It's all right. Anyone else brave enough to hazard a guess?
Mark, no one remembers the names of the fissures.
One second. All right. Yeah, oblique. There you go.
Oh, someone does. Oh.
Someone actually remembers. Yes, there are, because the left lung is split into two lobes, there's only one fissure, and that is the oblique fissure, right? So the right lung is split into three lobes. So there's two fissures. One is the oblique, which separates the upper from lower, and well, the upper and middle from the lower. And then what separates the upper from the middle is the horizontal fissure. I will not make you guys tell me all the segments of the different lobes. That will be a bit mean. Okay, anyone want to comment on this one? Any idea which side of the lung, whereabouts the abnormality is, if there is any?
Hint, it's a pneumonia.
Okay, yes, it is consolidation, it is right, and it is lower zone. So actually, yes, that is a good description. Do you want to try and narrow down anatomically which lobe it is? Like I said before, so which, based on like the haziness of the right heart border. I'll give you a hint there.
So yeah, just remember, zones are literally the positions on the chest X-ray. Lobes refer to anatomical locations. That's the difference between the two, if anyone asks you.
Very good, middle. Yeah. So we've lost the right heart. We've lost the nice clear definition of the right heart border because of the consolidation. So this is most likely a middle lobe pneumonia. But really a very good description in terms of the chest X-ray. It is a lower zone consolidation on the right side. Yeah, there we go. Anyone spot the abnormality on this chest X-ray? Does anyone want to try and interpret this chest X-ray over voice? It's all right if you don't. You can raise your hand and do it. Cavitating lesion. Good. Yeah. Which lung and which area of that lung? So good spot on the cavitating lesion, but remember, there's no point telling me there's a lesion if not where. Good. Right upper zone. Good. Right up. So this is right upper lobe or right upper zone cavitating lesion. What do you think the diagnosis is? What are some causes of cavitating lesions? This particularly in the right upper lobe. TB. Very good. Yeah. This looks like classic TB. And you can see there's a little bit of hilar enlargement on the right side as well. Actually, I can't. Unfortunately, I can't point it out when I say it. Yeah. Good. Anyone want? So yeah. So can someone tell me what they see on this chest X-ray? Don't worry if you don't get a diagnosis.
Most of you probably know the diagnosis, but describe this one first.
Yeah, you may or may not know the diagnosis. If you don't worry. Just give me a description of how the lung fields look in this. Bilateral consolidation throughout all zones. Yeah, I would take that. I would accept that as an answer, and it's a pretty good description of it. There is consolidation throughout both lung fields, and this is consistent with. Does anyone know? So one would be lung cancer. Lung mets aren't as they're a bit more well demarcated, and they're larger looking lesions. So they look more like if you took the X-ray and you shot it with a shotgun, it would look more like that. Like you have like pellet like lesions scattered throughout the lung. This is a bit more hazy. It's more inconsistent with fibrotic lung disease. No, you get different kind. That's a bit of a different ballpark. It's more fine reticular with also nodular like shadowing. I'll see if I can find you an X-ray to show you the difference. But
I'll find it in a minute.
Yeah. This is more in, no, it's all right.
Just to move it along.
They're good guesses, and it's good. You're kind of getting the ball rolling on what it's like to form a differential. You're getting, you're thinking. That's the most important thing. This is in keeping with Miller TB. Okay. But also, like I mentioned before, COVID kind of has this hazy bilateral consolidation looking chest X-ray as well. But this kind of appearance is classic of Miller TB. Miller TB is when a focus of TB disseminates throughout the lung. Okay. And patients will also have extrapulmonary involvement. It'll seed elsewhere. So it could seed in the bones. It could seed in the pericardium. It could seed in the gut. It could seed anywhere. Pneumothoraces. Pneumothoraces are
for the sake of time.
Yes.
I was just going to say, for the sake of time, you can probably read over the pneumothorax slides because they're pretty simple.
Yeah, actually, rather than.
So what we'll do is we'll quickly do how to interpret ABGs, and then we'll let you go grab dinner and stuff.
Yeah,
so we'll be done.
Cool. There's not really much left. It's just the pneumothoraces. Just if the lung markings don't reach the end of the lung, you've got a pneumothorax. That's pretty much it.
Yeah, look at those slides in your own time. Divya.
Hello. Oh, I think
her voice is working.
Have the slides just gone? Yeah.
Yeah, right. I'll share them again. So in the meantime, I will let me share the slides really quickly. I'm also going to ask you guys to give some feedback as to how it's gone so far. If you could send, if you know someone was here and then they left early, just send it to them. I'll post it in the group as well. So ABGs are pretty important, and Divya's got some slides on those as well. Have you had any teaching on ABGs out of interest? Have the slides loaded? Sorry.
Yeah, I'm just getting to the right slide. One sec.
Okay, my internet's just dying. In case anyone wonders why it sounds like I'm drowning.
Nearly there. Where is it? Okay. Okay, so you guys have already had some teaching. This isn't going to be super complex, but I just think ABGs are just a really easy thing to get asked about on the wards, and also exam, like SBA wise, they're very SBA-able. So I'm just going to give you basically some of the main examples that I think you should be able to interpret, and kind of the clinical situation that it might come up in. So basically that there is like the main things they show you. If you're ever with a consultant or a doctor when they're doing an ABG and you get a printout, there's a lot more on that piece of paper. There'll be like glucose, lactate, things like that. But obviously when you're like interpreting for like alkalosis, acidosis, the main things that you need are in that green box, and that's literally taken from our normal values booklet. So that's like the UCL ranges. So just quickly, they normally do the ABG in your radial artery. Occasionally they can do it from a femoral brachial, but it's like a quick procedure, and it's pretty easy. So if it's like a good thing for someone to do, if a patient's in a kind of bad clinical condition, they can, if they do an ABG, they can get a really quick picture of like how that patient's doing, and especially with respiratory conditions, it's quite useful. I've just put a little thing there about base excess because some people seem to get confused with that. It's literally basically just a marker for the bicarbonate. So if you've got a high bicarb, your base excess is going to be high. And if you've got a low bicarb, then your base excess is going to be low. It's just like a quick thing of like eyeballing it, and you can quickly see because the range is pretty straightforward. Okay, so there's basically 5 main steps to approaching ABG. So the first thing we want to see is the clinical condition of the patient. So that basically means that when you're interpreting ABGs, you want it to be in the context of how that patient's doing. So for example, if you have a normal PaO2, but a patient is receiving high flow oxygen, even though their O2 might be in normal range, that isn't necessarily normal, because if someone's on a high flow oxygen, you expect their PaO2 to be relatively high. Another example is, can anyone tell me if you've got an asthmatic that's having an acute exacerbation, so like an asthma attack, so they're hypoxic, and they have a normal CO2, why might that actually be an abnormal thing? Why is that not good? Does anyone know? So in an asthma attack situation. No? Yeah, exactly. You'd expect hypocapnia because they're breathless, they're trying to ventilate a lot to get oxygen in, so they're basically breathing off all their CO2. So when you see an ABG and like if they give you an ABG and a person's having an asthma attack and their CO2 is within the normal range, that's alarming, because it means their respiratory effort is failing. So they're breathing less, they're basically tiring out, and they might need to go to ITU because they're breathing less and they're retaining the CO2. So even though it's normal, it's not. So that's basically why you need to look at the clinical condition. Like, it needs to be relevant to the patient. Obviously, is a patient hypoxemic? Is their O2 low? I'm not going to do respiratory failure today because that's quite big. We can do that another time. But just as a general rule, it should be on, if a patient's breathing on room air, it should be over 10. And I think the range is 11 to 15. Obviously, are they acidemic or alkalemic? And then what's happened to the CO2? And then obviously also I'd add on like what's happened to the bicarb. So I'm going to do examples with you so we can go through it. I literally just took that from the Oxford Handbook. So that's basically what you'd expect from the different types of acidosis, alkalosis. So just the basic thing you need to know is that CO2 is an acidic gas. So if your CO2 is high and their pH is low, as in it's acidotic, then you know it's because of the CO2, because high CO2 makes the blood acidic. So alternatively, if their CO2 is low, they've got less acid in their blood, so they're alkaline. So obviously their pH is going to be high, and you can tell that's from a respiratory cause. And then, so I would just, you need to, I think it's easier to figure it out. You shouldn't just learn tables. I think there's like mnemonics you can learn about the different ways that if like the pH goes opposite. But I think if you are able to figure out the reasoning behind it, it basically, it will make just more sense to you. And then obviously bicarb is alkaline, and it's kind of the similar principle. You can refer back to that, but I think if you understand the basic things, that CO2 is acidic, bicarb is alkaline, like you should be able to figure it out. So I think if we go through some examples, and I'll ask you what you think is going on. So starting off, there's a flash on. Okay, right. So that's the normal values are going to be in the top right. Can anyone tell me what's going on in this ABG?
Can I just mention it's fully worth going over the Henderson-Hasselback equation for CO2 dissociation. It's like one of the few pre-clin things that's actually super useful.
Because it will help you, it'll help you understand kind of the reasoning behind it. But does anyone know what's happening here? Or what the disturbance is?
So is it acidotic or alkalotic to start with? Okay,
yeah, fantastic. Okay, so yeah, exactly. Oh, they've all just come through. Okay, so there's no compensation here. Yeah, exactly. So the pH is raised, so it's the patient is alkalotic. They've got a normal CO2, so there's no compensation, and obviously the cause of the alkalosis is not a respiratory cause. And then the bicarb, which is alkaline, is raised, and as a result, like I said, the base excess is raised because that reflects the bicarb level. So that's pretty straightforward there. And so just some context of when that might happen. Basically, like if you're vomiting, you're getting rid of like hydrochloric acid, so you're getting rid of H+ ions, so you're going to become alkalotic. Certain diuretics as well cause H+ ions to be lost in the kidneys, and some endo conditions like cons, if you think back to second year. yeah, so that's just like some examples. But if a patient's been vomiting, you'd expect them to be, and like they've not compensated, they're going to be metabolically alkalotic. Okay. Right. Can anyone tell me what's happening here? I do think. So this is metabolic acidosis. Yeah, so it's basically the CO2 has changed. So when basically we see here it's acidosis first off, the pH is low. The CO2 is low, but obviously in general terms, if your CO2 has gone down, you're blowing off an acidic gas, you would expect the pH to be alkaline. So that immediately tells you that the CO2 has changed in response to the bicarb. So it's tried to compensate. So the original cause of this is the bicarb, because that's low. So you've got less alkaline, you're becoming acidotic. And the CO2 as a result of that you're ventilating more, you're trying to sort of blow it off so that you have less acid in your blood, but you've not managed to completely compensate, hence why your pH is still not in the normal range. So a reason you might get metabolic acidosis is in DKA. Does anyone know what that is? Yeah. Yeah, good. So you're basically, that's when a diabetic patient, it's a diabetic emergency, they've not got enough insulin, their glucose is high, and they're basically pushed into the starvation state, so they start producing ketones as energy, and ketones are acidic. So that's a classic cause of metabolic acidosis, would be DKA. And then, yeah, if you're not excreting enough acid from the kidneys, or you're losing a lot of bicarb, you might get this. Next one, if anyone wants to have a go at that. I can see why you say that, but not quite. Have a look, remember, start at the pH. This is a slightly harder one. Yep. Yep, is okay. So it's a metabolic alkalosis. Nearly. So this is quite tricky. So obviously you've started at the pH and it's normal, but you can immediately see that CO2 and the bicarb aren't within normal range. So the way to think about this is you're slightly on the pH, you're slightly towards a more alkaline side of the range. You're 7.42. So the thing out of the CO2 and the bicarb here, which of those two things, the one that's raised, they're both raised, but a raised bicarb is the one that would have caused the alkalosis, like because it's closer to the alkalotic range. And as a result of that, your CO2, you've basically tried to keep in your CO2, so to basically make your blood more acidic, and you've basically fully compensated by doing that. So you want to look at that range, and if it's normal, but if it's on the end closer to the alkaline, then you want to see like which of the CO2 and H2O3 could possibly lead to that. Does that make sense? Anyone have any questions about that? It's kind of confusing to explain.
Just remember that the body never overcompensates. Like,
yeah,
the body will not overcompensate. So you have to look whether it's above 7.4 or below 7.4 is a big giveaway in that.
Yeah,
it's like a really hard question if that comes up.
That is quite harsh. I'm not sure they would just give you one ABG with that, but yeah. So you're basically exactly like I said. You're looking, is it above 7.4 because that's a halfway range that's a midway point, or is it below it? And then you can figure out what is the initial thing that's happened here to cause that change. I think that's probably the only example I have when it's fully compensated, maybe. But that's just something to bear in mind. Okay, good. What's going on here? Yeah, so we've only partially compensated here. That's good, that's correct. But it's respiratory alkalosis with partial compensation because your pH is still out of normal range. So starting with pH again, it's high, so you're alkaline. And the CO2 is low. So we know that the cause of that the pH being alkaline is because you've not got enough acid. So obviously it's a respiratory cause here. And as a result, your HCO3 is you're trying to reduce that to compensate. So you have less alkaline in your blood. And just a note with metabolic, if like the HCO3 has changed with CO2 to compensate, it's very easy for your body to compensate CO2, isn't it? Because you can just breathe quicker. So you can very quickly change the levels. With HCO3, if you see on an ABG that the bicarb has changed, it's generally taken a few days for that to happen because the kidneys just take longer to alter that, basically. That's just something to remember. So does anyone know why it's quite common? This is a classic thing they like to put in because it's like just an easy thing. It's not, you probably wouldn't think of it, but what is a reason you might get a respiratory alkalosis? Ignore the compensation. Why might you get a respiratory alkalosis? It's not super medical. Yeah, exactly. Well done. So basically, if you're having a panic attack, someone's ventilating very fast, they're breathing really quickly, they're blowing off all their CO2, so their pH increases. Exactly right. So basically, I think respiratory alkalosis is easier to remember because it's conditions generally that are going to make you breathe faster and blow off your CO2. For example, with a PE or a pneumothorax, the patient is breathless, they're kind of hyperventilating, and when you're in pain, your respiratory rate goes up. So all the things that cause your CO2 to be released are going to give you a respiratory alkalosis. And yeah, or if they're on a ventilator and you're obviously deciding their respiratory rate and you accidentally set it too high, they'll become alkalotic. I think this is one of the last ones. Does anyone know what this is? Oh, second to last. This is a bit
while
harder.
While you're figuring that out, just one other thing to remember is respiratory compensation is quick. Metabolic compensation takes a lot longer, just generally, as a rule. Just a useful thing to remember.
So that is correct. It is. And what else is it though? It is respiratory, but have a look at the bicarb. Yeah, exactly. So you can, you're very unlikely to get this, but just to bear in mind, because it's mixed, exactly. So you've basically got a mixed respiratory and metabolic acidosis. So just always, that's why it's important to just always look down. You don't just stop at the CO2 because you never know. I'm sure they'd be a bit mean to chuck things like this, but so the pH is low, it's acidotic, CO2 is high, and the bicarb is low. So both of those things would cause an acidosis. So you might get that in basically multi-organ failure. So sepsis, you start respiring anaerobically, your lactate will build up, and yeah. Yeah, always read through the whole ABG. Your lactate builds up, so that's causing the metabolic acidosis, and then basically your lungs will start to fail as well. So then you're also getting CO2 buildup. So just that would be quite nice to remember, like in cardiac arrest or sepsis leading to multi-organ failure, you're probably going to get a mixed acidosis in that case. Okay, last one. Okay, I have done one harder one again, but this is the last one. Similar to one we've done before. Does anyone know what this is? Yeah, exactly. Well done. It's fully compensated. So again, the first thing you're looking at is a pH. And it's normal, but it's below 7.4, so it's obviously towards the acidotic side. So of those results, the thing that would have caused the acidosis would have been the high CO2, and then the body's realised that, so your bicarb is compensating, trying to increase the pH by increasing the amount of bicarb in the blood. So that's exactly right. Just remember the 7.4 rule. And again, like we said before, if you've got a metabolic alkalosis, you know that this has been compensated over a period of time. So can someone think of a chronic condition where you might see this kind of picture. Someone might have a kind of chronically slightly raised bicarb and a high CO2. So respiratory, yeah, exactly, COPD. So they're basically, I'm sure you've heard a lot, there's two types, but generally COPD, a lot of them are kind of CO2 retainers, and their body has chronically, their kidneys have chronically compensated for that by increasing the bicarb. Also opiates, because they decrease your ventilation rate, so you're retaining the CO2. Does anyone know what Guillain-Barré is? You'll come across this in neuro this year. It's a bit niche, but I think it is on the curriculum app. Don't worry if not, it's kind of niche. Yeah, exactly. So it's basically an autoimmune mediated demyelination of the peripheral nervous system. And it's I think is it descending or ascending paralysis? I can't remember. I always get confused which way.
There's two types.
Oh, okay.
So it can be either.
Oh yeah, okay, fine, yeah. So, and eventually basically you get paralysis, so you're not ventilating again. It just comes back to that, and you're retaining your CO2. And yeah, you might get a mild thing, same thing with asthma as COPD. Okay, those are I think that's a pretty good spread of examples of what you're going to get. That's in there is probably the hardest ABG you're probably going to be asked to interpret. I think most of them are going to be a bit easier, the more standard ones. This is just a quick thing at the end. Don't worry too much about this, but I think some people get confused by the anion gap. You don't need to know a lot about it. You just basically need to know that you use the anion gap. Yeah, that's literally, I've thought of every example I could possibly think of. But UCL probably won't do as many of the mean ones I've done. So the anion gap is basically just used to work out the cause of a metabolic acidosis. That's just what you need to know about it. That's the equation. And that is a normal range from the UCL normal values booklet, it's 10 to 18. So you're basically subtracting the positive ions, the negative ions from the positive ions added up. So basically, you're going to get an increased anion gap, or you're going to get a normal anion gap, and there's certain conditions that are going to cause either of those things. I think the increased anion gap is easier to think about because it's literally increased because you've increased the amount of acid. So it's then easy to think of things like with lactic acid. So like I was saying before, with sepsis and organ failure, you're going to increase your lactic acid. And anything that causes that increase in lactic acid is going to be a cause of an increased anion gap. Again, ketones, so DKA, you're going to have that. Also, yeah, if you drink alcohol as well, that increases ketones. There's some drugs there I wouldn't bother learning all. I mean, that's very, very unlikely, those drugs at the bottom to come up. But yeah, those are just some examples you can look back at. But I think the increased anion gap is slightly easier to think about because it's you're adding acid. So with DKA, you're adding ketones to your blood. Oh yeah, actually aspirin. So salicylates. So aspirin is probably, you might want to remember that causes an increased anion gap. The other are a bit random, I think. And then things that cause a normal anion gap. I mean, you can learn these if you want. The only way I remembered some of these was just that a lot of them began with an A. So renal tubular acidosis. Drugs, I remembered acetazolamide, I can never pronounce that. Addison's disease and ammonium chloride ingestion. I mean, I think I would remember renal tubular acidosis, especially that causes a normal anion gap, because it can be useful in an exam question if they kind of give you the means to calculate an anion gap and you're kind of stuck between two options, but you might know for sure that one of those conditions causes a normal anion gap. So, you can get to an answer maybe quicker. But don't worry about learning really long lists. I think Anush added this. Yeah, always learn the shorter list because it's just easier. And then you can, for example, for me, I think I mainly focus on these A's and also salicylates like aspirin. And as I said, the increased anion gap is just an easier thing to kind of work out in your head anyway. Yeah. So that was a bit of a whistle-stop tour of ABGs. If anyone has any questions, you can post now or you can message me after on Facebook, I don't mind. Some of those examples were a bit harder, so don't worry if you didn't really fully get it, but we're going to give you the slides and hopefully if you work through it, it'll make sense, or just ask me, I don't mind.
Yeah, I'll post the feedback link again. It's really useful. You're probably going to say that the session was a bit long, which I agree, but I can promise you that none of the other sessions are going to be this long.
No.
It's just these are 3 things that you will see in your first week, so we kind of wanted to get through them. But yeah, from next week it'll probably be like an hour and a quarter max, and we'll try and do something that's relevant to all 3 of the modules. If anyone asks, this is recorded. I will upload this and post a link for YouTube. I will also post a link to the folder where every single set of slides we produce you'll be able to find. You can just save that hyperlink, and you'll be able to get all of them. If you've got any questions, yeah, I can stick around for like 5 or so. I'm sure the others can as well, and we can answer them now. It's up to you. I'm glad you found it useful. Where will the link be? Yeah, so the Facebook group I made, I'll post like one thing with all the links you need, and then I'll just pin it so you have it for easy access. Yeah, I think all of us are happy to be messaged if you have queries. So yeah, just drop any of us a message for anything. What's HB? So HB, I'll stop recording 1 second.